tract. Okay, so our objectives would be, of course, to learn the anatomy of the esophagus, discuss the stomach, its major parts and blood supply, discuss the divisions of the small intestines, describe characteristic features of all the divisions of the small intestine, discuss parts of the large intestine and the characteristic features of each division of the large intestine. Okay. So basically, the gastrointestinal tract, also called your digestive tract or your alimentary canal, it is a continuous tube that extends, of course, from the mouth to the anus. And as it goes down, it passes through, of course, your thoracic cavity and also your abdominopelvic cavity. Okay, so organs included, of course, in this tract would be the mouth, pharynx, the esophagus, stomach, small and large intestine, up to the rectum. Okay. Now, as it do its function, it involves several processes, of course. First, we have the ingestion of food. Okay, ingestion, and then there would be, as the food is broken down into pieces, it would be through the help of your salivary glands secreting your salivary enzymes, and then the food would pass through your pharynx down to the esophagus, and then in the stomach, it would be another process would be involved, your digestion, and then in the intestine, another process involved, your absorption, and then there would be the excretion or your defecation. So basically the function of your GIT involves several processes. Okay, but we will be focusing our discussion today starting with the esophagus. I will not be including the oral cavity because you already have a detailed discussion on that in your head and neck module. Okay, so we will be starting our discussion by discussing the esophagus. Okay, so let's start with the esophagus. The esophagus, of course, this is a muscular tube, approximately 25 centimeters. It conveys food from the pharynx to the stomach. So it begins at the level of the cricoid cartilage. Now, the cricoid cartilage, it is a very important landmark. It is located at what level in terms of your vertebra? It is located at what vertebral level? You should be very familiar with this. The cricoid cartilage is at the level of what?
9.
Oh, it's not C9. It is? Well, of course, first of all, is there a C9? My question is there a C9?
No, doc.
No. Okay. So you're wrong. It is C6. Don't forget that. It's C6. Okay. So the cricoid cartilage is at the level of C6 or somewhere here, up here. That's the start. That's where your esophagus starts and ends at this level as it enters your stomach. Okay, at the gastroesophageal junction. Of course, you will notice here that as it enters your stomach, it passes through an opening in your diaphragm. What is the corresponding level of that opening?
T10.
Okay, don't forget that. These are important things that you should know. You should remember. This passes through your opening at the level of T10. Okay, so that's your diaphragmatic, that is your esophageal hiatus in the diaphragm. Okay, so again, this is looking at it laterally. You will see that it follows the curve. It follows the curve of your vertebral column there. That's your esophagus there. Okay, so looking at this, you will know that it has a cervical portion, of course, in the neck. It has a thoracic portion and a very small abdominal portion. Okay, so those are the divisions or the parts of your esophagus: a cervical portion, a thoracic portion, and a very small abdominal. And this is approximately 15 centimeters from the incisor teeth. Now, okay, endoscopists usually use the incisor teeth as a reference point. Okay, so this junction is approximately 15 centimeters from your incisor teeth. Okay, and this there is a constriction in this area because of the presence of your cricopharyngeus muscle. Okay, so this cervical constriction actually corresponds also to your upper esophageal sphincter. Okay, the next constriction would be located somewhere here. There, the constriction is at this portion, and this we call it as your bronchoaortic constriction. Now, that constriction is because it is in this area where your arch of the aorta would be crossing your esophagus as well as your left primary bronchi. Because of those crossing over your esophagus, this causes the constriction in that part. So sometimes they call that constriction as your bronchoaortic constriction. Okay, so again, another constriction within this area here. And another constriction occur as it passes through the esophageal hiatus. There, as it passes through that hiatus, there is another constriction known as your diaphragmatic constriction. Okay, it is very important that you know these constrictions because awareness of these constrictions is important when passing instruments through the esophagus. Okay, your endoscope, as it passes here, you should be aware of those constrictions. So you have to be very careful. And also when viewing your X-ray, when viewing your difficulty of swallowing, one consideration would be any abnormalities involving the esophagus. Okay, your dysphagia. Okay. Now, aside from these three constrictions, very important to know that there are two sphincters. But actually, these two sphincters were already mentioned. The upper esophageal sphincter corresponds to your first constriction, your cervical constriction. And this is due to the presence of a skeletal muscle that separates the pharynx from the esophagus. That is your cricopharyngeus muscle. While your lower esophageal sphincter is a smooth muscle that separates the esophagus from the stomach. And this is very important because this prevents your gastroesophageal reflux. Again, we will be discussing this more later. Okay, did you get that? 3 constrictions, 2 sphincters. These are important parts of your esophagus. Okay, now, take note of this important area here. This is known as your esophagogastric junction, or the surgeons and endoscopists designate this as the Z-line. Okay, so this is the Z-line, a jagged line where the mucosa abruptly changes from your esophageal mucosa becoming gastric mucosa. Okay, so that is that junction. Okay, remember, this esophagogastric junction or your gastroesophageal junction lies to the left of your T11. Remember, it's at the level of your 11th thoracic vertebra. Okay, so that is at the level of TV. Now, going back to your opening of your diaphragm, this is your diaphragm there. And there is an opening there. Again, that corresponds to your T10, right? Now, notice that this esophagus is actually attached to the margins of this opening here through your, what do you call this? This is your phrenicoesophageal ligament. See, that is your phrenicoesophageal ligament. There. What is the purpose of this ligament? This ligament permits independent movement of the diaphragm as it takes part in your respiration and the function of your esophagus during swallowing. So 2 independent movements, swallowing here and respiration. Okay? That's the function of your phrenicoesophageal ligament. Okay? Now, again, very important, is immediately superior to this junction, that is where you will find your constriction. That is your lower esophageal sphincter. That lower esophageal sphincter, that is very important, because if there is failure, if this sphincter fails to close adequately, then there is the tendency of food coming from your stomach to reflux back here. Reflux, right? And you call that, what do you call that condition? You are familiar with that condition. That is your GERD, gastroesophageal reflux disease. Okay? So food from your stomach would be refluxing back up here. And remember that your stomach content make stomach food, your food coming from here would be containing hydrochloric acid, right? Hydrochloric acid from the water in a region here related to a cardiac problem. That's why we call it heartburn, okay? Not actually related to cardiac problem, okay? So your heartburn is your secondary to your GERD. Okay, now blood supply of your esophagus. As I've mentioned earlier, your esophagus is actually divided into parts. Your cervical esophagus, that's in the part of the neck, thoracic esophagus, and your abdominal esophagus. The cervical esophagus, of course, would be supplied by your inferior thyroid artery, which is a branch of your thyrocervical trunk, from your subclavian, and then your thoracic esophagus would be supplied by your branches coming from your descending thoracic aorta. And this abdominal esophagus, this is a very small part, abdominal esophagus, of course, would be supplied by your left gastric artery, and sometimes your left inferior phrenic also, okay? And then, of course, your venous drainage would be, it would be draining into your inferior thyroid thoracic, in the esophagus, the thoracic esophagus would be draining into your esophageal plexus of veins, while your abdominal esophagus would be draining into the left gastric vein. Okay, now your left gastric vein would be eventually draining into your portal vein. Okay, and because of this relation, sometimes if there are problems in your liver, like if there is cirrhosis of the liver, esophageal varices may happen. And that is because of the presence of this left gastric vein draining into your portal vein. Okay, so esophageal varices. Okay, so shown here, of course, again, this is a cross-section of your esophagus showing your innervation. So basically, innervated by your upper portion would be innervated partly by your hypoglossal nerve, because this is made up of your skeletal muscle. While the lower portion, you will be seeing this mesenteric plexus, your esophageal plexuses of nerves, which is actually part of your autonomics, partly part of your parasympathetic and your sympathetic nerves, innervation. Okay, so that would be the innervation for your esophagus. Okay, now next would be the stomach. Okay, so the stomach, of course, here, the esophagus would now continue here, continuous with your stomach. So the stomach, this functions both as a reservoir and as a digestive organ. Okay, so it empties its contents in small portions suitable for continual digestion into so it would continue now with your small intestine. Okay, so the stomach actually acts as a reservoir, but its chief function, remember, its main function is enzymatic digestion. Parts, so you are familiar with this. You have the cardia here, a very small part would be the cardia near the gastroesophageal junction, and then you have the fundus here, the stomach, the body of the stomach, that is the largest part, and of course you have the pylorus here. These are the different parts of your stomach. Okay, of course, the cardia here, in the supine position, remember this, that the cardial orifice usually posterior to the 6th left costal cartilage. Okay, so again, that corresponds to the level of the T11 vertebra. Remember, your gastroesophageal junction occurs at this level, T11. That means the cardia of orifice is located in that area. Okay, so that's your cardia. And of course, related to your cardia would be your cardiac sphincter. This cardiac sphincter actually corresponds to your lower esophageal sphincter. That's it. That's your cardiac sphincter. That corresponds to your lower esophageal sphincter also. Okay? Next would be your fundus. This is the fundus. That is the dilated superior part here. And that is, of course, related to the left dome of the diaphragm. Okay? So, in between your cardia and your fundus, there is a notch there. That is your cardial notch. Okay? And this part here, the fundus, it may be dilated by gas, fluid, food, or any of combination of these. Okay, that's your fundus. Next, you have the body. So, the major part, of course, of the body, of the stomach would be the body, between the fundus and of course your pylorus, that's the body. And the last part, a very important part, of course, would be your pylorus. This is your pylorus, the funnel-shaped outflow region. Outflow meaning coming from the stomach, it would now continue with the contents of your stomach would now enter your duodenum. And then a very important function, part there would be your pyloric sphincter. This is a specialized valve that prevents, again, materials from the and digestive enzymes from escaping into the small intestine before digestion is completed in the stomach. Okay? That's your pyloric sphincter. Next, we have the curvatures. Okay, be familiar with this. You have your lesser curvature here. It forms the shorter concave. Actually, it forms the right border of the stomach. That's the lesser curvature. And of course, the longer convex left border of the heart, of the stomach, I mean, would be your greater curvature. Okay? Related, of course, to your lesser curvature would be your lesser omentum, right? And then it would extend here and then continue here as your greater omentum. Are you done with your abdominal wall lecture?
No, Doc.
Not yet? Okay. Okay, so remember that. Lesser curvature, greater curvature. Now, the lowest most part of your lesser curvature, the lowest most part, you call that as your angular incisure. That is the most inferior part and that indicates the junction of the body and your pyloric part. That's your angular incisure. Not so much, not very prominent here, but in some images, you will be able to appreciate really your angular incisure. Okay, that's the angular incisure. Okay, now relations of stomach, very important. Anteriorly, of course, the stomach would be related to the diaphragm. Of course, the diaphragm is here. To the left lobe of the liver here, of course, the anterior abdominal wall. Those are the anterior relations of your stomach. While posteriorly, of course, you have the omental bursa, the pancreas is behind your stomach. And of course, here, inferiorly, you will see the relation here related to your transverse colon. There, that's the transverse colon. It is related inferiorly and of course, laterally as it courses along the greater curvature here of the stomach to the left colic flexure. So this is your transverse colon, and this is your left colic flexure. There. Okay. Okay. Now, okay, review. Very important. Again, anatomy is all about relations, position. These are the things that you should know. Going back to your cardial orifice. That's the opening. Again, at what level? See, that is your 6th. Yes. Looking at your picture, looking at this image, you can see that it is at the level of your 6th costal cartilage. While your fundus here would be related to what? To your 6th rib, posterior to your 6th rib. See? That there. This is in the supine position. Okay. Now, a very important thing also to note is your pylorus. Your pylorus actually passes through the transpyloric. That's why it's called transpyloric plane. This is your transpyloric plane. And that transpyloric plane actually transects the 8th costal cartilage. See, that's the 8th costal cartilage. There. Remember that, the 8th costal cartilage. And in terms of your vertebral level, this actually corresponds to your L1 vertebra. Okay? So these are the important relations. So this is your midclavicular line. Be familiar with your midclavicular line. This is your pyloric line. This is your transtubercular plane. Okay? So these are important things to note. Okay, now, the so-called bed of the stomach, these are the parts where your stomach rests like a bed, right? In the supine position. And this is formed by these structures. So, of course, partly by the dome of the diaphragm, the spleen, the left kidney, the suprarenal gland, the splenic artery, the pancreas here, the transverse mesocolon. Okay? This is the so-called bed of the stomach. So basically, they are more on the posterior aspect of your stomach. Okay? Now, inside your stomach, you will see folds. Okay? You call these folds as your gastric folds or your rugae. Longitudinal ridges or wrinkles on the gastric mucosa. What's the purpose of these rugae or folds? Of course, they would accommodate. Remember, food would enter your stomach. So in order for the stomach to accommodate that much food, it has to expand. And that is only possible through these gastric folds. Or you call this as your rugae to increase surface area. Okay? So that's the interior of your stomach. Blood supply of the stomach. Of course, this is the blood supply would be coming from your left and right gastric arteries. Your left and right gastric arteries would anastomose here in the border of your lesser curvature. Okay. So the left gastric artery arises from the celiac trunk. So you have a lecture on this in your cardiovascular system, right? Blood supply of the abdomen, right?
Yes,
so you're
Doc.
familiar. Yes, so you're familiar with your blood supply of the entire gastrointestinal tract, right? So for the stomach, it arises from your celiac trunk. Your left gastric artery would come from your celiac trunk here, while your right gastric artery would be coming from your hepatic artery, which comes from your celiac trunk. Okay, and these two would anastomose here in the lesser curvature of your stomach. Okay, then another blood supply would be the right and left gastroepifloic arteries, and again anastomosing, this time in the greater curvature. Okay. Also, supplying the stomach would be short gastric arteries coming from your splenic artery. Your splenic artery, again, is a branch of your celiac trunk, a very large artery. And that splenic artery would also give off your posterior gastric artery there to supply basically the fundus. So your fundus here, that would be supplied by your posterior gastric artery and also portions of your short gastric arteries. Okay? These are the arteries that would be supplying your stomach. Venous drainage would be going to your superior, of course, to your superior mesenteric vein and your splenic vein. So the right and left gastric vein would be going to your portal vein. Your left gastroepiploic and short gastric would be going to your splenic vein. And then you have your right gastroepiploic vein. Okay. Eventually, they would be draining to your portal vein. So this would be discussed more. Your portal vein is actually formed by the superior mesenteric vein and your splenic vein. This will be discussed more, I guess, in your next lecture in GIT. So I will not be discussing this in detail. Okay, so that would be the venous drainage of your stomach. Okay, now next we have the small intestine. Okay, so basic function, of course, of your small intestine would be absorption. So 90% of absorption occurs in the small intestine. Okay, and the small intestine has three parts. Of course, you have the duodenum, the jejunum, and the ileum. Duodenum, jejunum, and the ileum. Okay, so the first part would be your duodenum. This is the first part, the shortest of the three, and also the widest, and also the most fixed part. Okay, it follows a C-shaped course. Pancreas. So this is the head of the pancreas. This is your C-shaped duodenum. And most of the duodenum okay, it has four parts. Of course, you have the first part. Of course, it is also called as your superior, and then it would descending part, and then this is the ascending, the horizontal part, transverse or the horizontal part, and then of course it would ascend again. That's why it's called the ascending part. Okay, so 4 parts. Okay, so the superior part, this is a very short part. This is only approximately around 5 centimeters anterolateral to the body of your L1. Okay, L1. So this is continuous with your pylorus. That's why it's at the level of L1, right? So this is the continuation of your pylorus. Okay, so it lies anterolateral to the body of the pylorus. It ascends there, and that would be the first part. Then this is followed by your second part. So this is your second part. The second part would be the descending. This is longer. This is around 7 to 10 centimeters. There. Descends along the right side at the level of, remember, this is L1. Okay, so this corresponds to L1 to L3. There, the entire second part, L1 to L3. Curving around your head of the pancreas. Very important part, because this is the area posteromedial to this part. That's the area where your bile duct and your main pancreatic duct would enter. Okay, on the second part of the duodenum. And then next we have the horizontal part there. That's the horizontal. Okay, so SMA. So now the structures would be coming, the structures, the blood supply of the structures here would be coming already from your SMA. No more branch from your celiac trunk. Okay, so the superior mesenteric artery there would give off your jejunum and ileum branches, your jejunal and ileal arteries, and then these arteries would unite to form loops or arches called arterial arches. And they would give off now, these are the arterial arches, and then eventually they will give off your straight arteries known as your vasa recta there. Okay, so this is your small, your jejunum and ileum, supplied by your branches coming from your SFA. Okay, venous drainage, we just follow also the artery, and then basically the drainage would be going into your superior mesenteric vein. Okay, now lastly, we have the large intestine. So the large intestine, this is where water is absorbed from the indigestible residues of the liquid chyme, converting it into semi-solid stool or feces. So water is absorbed here now in this portion of the colon, of the digestive tract. And this large intestine consists of the following. Of course, you have the cecum. Continuous with your ileum is the cecum, ascending colon, then you have your transverse colon, descending colon, the sigmoid, and then the rectum. Okay, and in the cecum, part of the cecum, you will find your appendix. So the large intestine can be distinguished from the small intestine by the presence of the following. First, you have your omental appendices. So this is only present in your large intestine. These are small fatty omentum-like projections. Then you have your tinea coli, again, only present in your large intestine. These are thickening of the longitudinal muscularis. So made up of 3 distinct bands. You have your mesocolic tinea, the omental tinea, and the free tinea. And then lastly, you have your haustrations, your haustra. These are the circulations on the wall of the colon. Okay, so this one here. See, these are the circulations present only in the large intestine. These are the tinea coli, again, present only in your large intestine. And then you have your projections here, not so much visible here. Your omental appendices, again, present only in your large intestine. So the first part of your large intestine would be the cecum. Okay, so this is the cecum here, continuous with your ileum. It is a blind intestinal pouch, approximately 7.5 centimeters in both length and width, completely covered by peritoneum. Lies in the iliac fossa in the right lower quadrant. Attached to it, of course, would be your appendix there. That's your appendix, posteromedial surface. That is the appendix. Okay, so relations of your cecum, lateral third of the inguinal ligament. Of course, it is related. Anterior to it would be the coils of small intestine. And then posterior to it, you will find your psoas, your iliacus muscle, the femoral nerve. And then, of course, appendix is commonly found behind the cecum. That's the usual location of your appendix, behind the cecum, retrocecal. Okay. Of course, now appendix. Okay, so the appendix, this is a blind intestinal diverticulum containing masses of lymphoid tissue. So when you go to your histology, you will histologically you will find here lymphoid tissue. Okay. And then this appendix, as you can see, has a small mesentery. You call that as your mesoappendix. Now take note that your cecum, it's entirely covered by your peritoneum, but it has no mesentery. That's the cecum. While in contrast to your appendix, it has a small mesoappendix containing the appendicular vessels and nerves. Okay. Your appendix actually has several positions, but the most common would be the retrocecal, meaning behind the cecum. There. That's the usual position, retrocecal behind the cecum. Other positions would be pelvic. There. Subcecal. That's the subcecal, below the cecum, subcecal. It could be anteilial or preilial. So this is your ileum. So anteilial or preilial. And in some cases, it's behind the ileum, retroileum. Okay? So these are just some of the positions, noted positions of your appendix. Again, the most common would be retrocecal, followed by your pelvic position. Now, take note also of your so-called McBurney's. What is this McBurney's point? McBurney's point, it is the junction. So you draw a line from your umbilicus to your right ACs, draw a line there, and then on the lateral third, you call that as your McBurney's point. This is the site of maximum tenderness in your acute appendicitis. That's your McBurney's point. Okay. Blood supply of your appendix would be an appendicular artery, which is actually a branch of your ileocolic artery. Venous drainage would be it would be draining into the ileocolic vein, going to your IMV, and then your lymphatic drainage would be into your superior mesenteric nodes. Okay, so that would be your appendix. Okay, a very important clinical condition, of course, related to your appendix would be your appendicitis. Know the clinical presentation of your appendix. This is usually commonly asked in the exam. Okay, your appendicitis. Next would be the colon. Okay, so the colon, it has 4 parts. You're familiar with your colon. So we have the ascending, you have the transverse, the descending, and of course the sigmoid. So here you can obviously see the characteristic features of your large intestine. So I already told you about the omental appendices, the tinea coli, and of course the haustrations or your saculations, the haustra. Okay, so the ascending colon, that would be the second part of the large intestine. That's the ascending. Obviously, you can see it is less wide than your cecum. It passes superiorly on the right side of the abdominal cavity from the cecum until it reaches this flexure here, the right colic flexure, or you're also called the hepatic flexure. Okay, so it lies in a groove here. Lateral to that, there is a groove here between your adjacent abdominal wall and the lateral aspect of your ascending colon. You call that as your paracolic gutter. Okay. Okay, so this right colic flexure here, or your hepatic flexure, this lies deep to your 9th and 10th ribs. That's an important location also. Okay, so that's your right ascending, that's your ascending colon and your right colic flexure. Okay. Paracolic gutter here. So blood supply of your ascending colon would be coming from your branches from your called marginal artery or your juxtacolic artery. Okay. This is your ascending. Next, we have the venous drainage, of course, would be through your ileocolic vein, right colic vein, all draining into your superior mesenteric vein also. Okay. Next would be your transverse colon. This is your transverse colon. So from the right colic flexure, it would now go to your left until it reaches your left colic flexure. Now, take note that the transverse colon, this is the longest, and this is the most mobile part of the large intestine. It is about 15 inches long. Okay, it turns inferiorly there, more acute, and becoming the descending colon there. Okay, so that's your transverse colon. Now, you will notice that the left colic flexure, as compared to the right, would be more superior, it is more acute, and it is less mobile than the right colic flexure. It lies anterior to the inferior part of the left kidney and attaches to the diaphragm through the phrenico-colic ligament. That's why it is less mobile. Okay, so this is your phrenico-colic ligament here, there. Okay, there. It attaches this flexured part of the colon here to your diaphragm. That's why it's less mobile. Okay. Okay, so here you can see that the transverse colon and its mesentery, it has a mesentery, the transverse mesocolon, it loops down, often inferior up to the level of the iliac crest here. Okay. Here. It can loop down to that level. Blood supply would be coming again from your middle colic, right and left colic arteries, forming anastomosis, taking part in this so-called marginal or your juxtacolic artery. Okay, here. Okay. And then venous drainage would be through the superior mesenteric vein, and then lymphatic drainage would be to the superior mesenteric lymph nodes. Okay, now again, okay. The next part would be the descending colon. The descending colon would be from your left colic flexure going down here. It is about 10 inches, occupies already a retroperitoneal position. Peritoneum covers the front and the sides. Okay, that's why somehow it is already retroperitoneal. Only the anterior part is being covered. Okay. And then the blood supply would be coming from your left colic and your sigmoid branches of IMA. Now, take note that the first transition in the blood supply occurred at the level of in the duodenum, right? The second transition would be happening here in the left colic flexure. So from that flexure, the blood supply going proximal would be coming from your SMA, and then distal would already be coming from your IMA. Okay, so this is your IMA already, your inferior mesenteric artery. Your last part of your colon. So this extends from the iliac fossa to the third sacral vertebra. Okay, so this is around 10 to 5 inches long as a continuation of your descending colon. It is mobile. It hangs down into the pelvic cavity in the form of a loop. Okay, it has a long mesentery called the sigmoid mesocolon. And you will notice that the omental appendices are starting to disappear because the termination of your tinea coli, that would already indicate the start of your rectum. Okay, that indicates the recto-sigmoid junction, the beginning of your rectum already. Okay, so blood supply again would be coming already from your branches, from your inferior mesenteric artery, the last transition in the blood supply. Okay, and then venous drainage would be to your inferior mesenteric vein. Okay, now take note that your sigmoid colon has a long mesentery, the sigmoid mesocolon, and therefore it is actually has a lot of as is freely movable. Okay. And because of that freedom of movement, especially in the middle portion here, this is prone to your rotation and twisting of this mobile loop, a condition known as your volvulus. Okay? Volvulus is common in this part of your colon, the sigmoid. Okay? Then last, we have the rectum. So the rectum, again, starts at the rectosigmoid junction. It is at the level of S3. Okay? And you can see here that this follows the curve of the sacrum and the coccyx. Here. It ends in anteroinferiorly at the tip of your coccyx, where it becomes continuous with your anal canal already. Okay? So laterally, you will see that it follows the curve of the sacrum And because of this flexure here, the sacral flexure and your anorectal flexure, it forms an S shape here on the lateral. On lateral view, you can see this S shape. Okay. So in males, you will notice that the rectum is related anteriorly to your urinary bladder, the fundus specifically, the ureters, the ductus deferens, the seminal glands, the prostate. Okay. That's why when you do your rectal exam, you can really appreciate some portions here, okay, especially your prostate gland when you do rectal examination, digital rectal exam. In females, the rectum is related anteriorly, of course, to your vagina, separated from it by these fornix and the so-called recto-uterine pouch. That's the recto-uterine pouch that actually corresponds to the lowermost part of your peritoneal cavity. See? There. Recto-uterine pouch. That's also the pouch of Douglas. Okay? Blood supply of your rectum would be coming from your superior rectal artery. Your superior rectal artery, it arises from your inferior mesenteric artery. Then your middle rectal artery, supplying the middle portion, would be coming from your internal iliac arteries, and your inferior rectal artery for the lowermost part of the rectum would be supplied by your inferior rectal artery coming from your internal pudendal arteries. Okay, and then blood supply would be through the same follows your arteries, superior, middle, inferior rectal veins. But take note that the superior rectal vein drains into the portal venous system through your IMV, while your middle and inferior rectal veins they drain into your internal iliac veins or your systemic venous drainage. Okay, so I guess that ends the lecture. I'm supposed to give a summary, but just make sure, just take note of the entire, starting the digestive tract, starting from the oral cavity and down to the rectum here. Okay, so that ends my lecture because it's almost time. I do hope you learned something from this lecture. Okay, thank you and have a good day.
Thank you, ma'am.